So we're done with the opening remarks. So now I would like to go to the first real session. So around PPH epidemiology, and moderating this session, I'd like to invite my good friend, Dr. Sherry Evans, is a midwife and senior maternal newborn health advisor at Chicago with over 30 years experience in clinical practice, education, and implementation research. And it was a key person in bringing all of this together for this meeting. So a big thanks to her. So Sherry.
Good morning, good afternoon, and good evening to everyone. And thanks so much, John, for that introduction. I have the privilege of moderating this distinguished panel of presenters on the epidemiology of postpartum hemorrhage. So I feel quite honored to be up to bat first. There's a lot of key information here. I'd like to just make one mention about the Q&A. For those of you who speak French, there may be a delay in getting your question translated. So if you're at all comfortable writing your question in English, we may be able to answer it more quickly. So just as we go through these really interesting sessions, questions are going to pop up. Please do put them in the Q&A. So to set the stage for the current environment and why we're all here in a virtual platform, I'd like to introduce our first panelist. So Dr. Mercedes Bonnet is a perinatal epidemiologist and medical officer based in the Department of Sexual and Reproductive Health and Research at WHO. She has extensive experience in global health research and normative work with a particular interest on maternal infections, care during childbirth, and the postnatal period. Dr. Bonnet?
Good morning, good afternoon, good evening, everybody. I'm very honored to be the first panelist in this meeting and have the opportunity to share with you some of the work that WHO is doing around the issues of COVID-19 in pregnancy. I cannot see my slides. But if you can just, yes, perfect. Okay, and you can go to the next one, please. So my presentation, in my presentation, I would give you a bit of a background around how COVID-19 is directly and indirectly affecting maternal health. And then I will present you the living systematic review that we are conducting in collaboration with the University of Birmingham. So take you through the methodology and then what are our main findings around prevalence of COVID-19 infection in pregnant and recently pregnant women. What do we know about clinical manifestation and outcomes both for women and for the babies, finishing with some key messages and providing you with some links at the end for additional WHO resources that I thought might be helpful for you. Next slide, please. Although my presentation will focus on the direct effects of COVID-19 infection in pregnancy, I thought that it was important for this audience to briefly touch some of the issues around what we think will be the indirect effects of this pandemic on maternal health and in particularly maternal mortality. There are two studies that have estimated maternal mortality and what we expect in the next year, given the current situation. So the first one is the estimates from Riley, and a second study is from Robertson, and is what I'm showing in my slides. So Riley estimated that about 28,000 additional maternal deaths will occur in the next year if we see a decrease of at least 10% of coverage of services during pregnancy, including antenatal care and care during childbirth. Kind of similar estimates were have been suggested by the second study, when they look at small reductions in the availability of health workers and supplies, and this might be mainly due to relocating some healthcare workers, for example, to work in certain hospitals, and then issues with hospital supplies to manage maternal complications. They estimated that around 24,400 additional maternal deaths will occur. However, if they take as a different model for their estimations, and they add into that disruptions into health systems, including disruptions in access, for example, for women to maternal health care services, combined with the strict movement restrictions, so people cannot easily reach the facilities, the estimates will be over 1,000 additional maternal deaths in the next year. What is, I think, interesting for you is that they look at different interventions, and they found in their estimates that up to 30% of this additional death will be due to limited access to parenteral uterotonics or access to blood banks. Having said that, and then moving to the direct effects of COVID-19 infection in maternal health, as you probably know, there has been an exponential growth in the number of studies that have been published around COVID-19 and pregnancy. This started with a few studies, initially from China, case reports, case series. Then we moved to having more data from observational studies, mainly in Europe and the US, and more recently, larger studies that have been published using comparative data and comparing infections, for example, in pregnant women and non-pregnant women of reproductive age, or between pregnant women with COVID and pregnant women without COVID. And I will focus my presentation in this last type of studies. Next slide, please. So in terms of the methodology that we are using for the living systematic review that we started in April this year, is that we are looking at multiple questions at the same time regarding the prevalence of the disease, how the disease presents in recently pregnant women, so to include postpartum women, but also those who had, for example, abortion. And then also looking in the future at, for example, prognosis studies and treatment of COVID-19 infection in pregnant women. So there's the link to the website that we have for the Living Systematic Review that has been also registered in Prospero. Next one. So we are currently, since April, performing weekly updates of searches and screening of the evidence, looking at a large number of databases, and also checking with other websites and groups that have been systematically doing mappings of the evidence without any language limit. And we are performing analysis of the evidence every 2 weeks with, and then rapidly peer reviewing the evidence using an external group of experts before posting some of the evidence that we found on our website. Next slide, please. So today I will present you results up to June 26. on the data that we have on prevalence, clinical manifestation, and outcomes of COVID-19 infection in pregnancy. In total, we identify 77 studies that provide some kind of information for these questions. And just looking at those that compare pregnant versus non-pregnant populations, and then pregnant women with or without COVID. As you can see on the slide, for the first comparisons, we have identified 8 studies with over 95,000 women included in those studies, and then 4 studies for the comparison of pregnant women with or without COVID, with a smaller total sample of over 2,000 women. And for this, of course, we are excluding all the case reports and case series that don't provide that type of information. An overview of the countries so far that we have been able to include in the evidence synthesis. As you can see, most of the data will be driven by data coming from the US and China and European countries, with a few studies now coming out from Brazil and Mexico. Next slide. So in terms of the prevalence of COVID disease in pregnant or recently pregnant women, what the evidence is telling us is that overall the rate of infection will be around 10%. And this is coming from 28 studies and up to 11,000 women included in those studies. And this is the prevalence of the disease among women who have been admitted or had been in contact with a hospital, and it doesn't include an overall population-based prevalence estimation. However, different countries and then within countries, hospitals have been using different strategies to test women for COVID-19 infection, going from universal screening among all admitted women during pregnancy or the postpartum period, for example, for any given reason, including for childbirth, or on the other side, for example, only testing women who show symptoms, sometimes only those who show severe symptoms, and they won't test women with mild symptoms, for example, asking them, depending on the policies of the country, to stay home, or also including testing if the woman has history of traveling to a zone of where community transmission is occurring, or if there's history of a contact who has been positive. So if we stratify the studies by the different testing strategies that they are using, you can see that in the universal screening sample, around 7% of women being in contact with a hospital will test positive to the virus among those who have been tested, in contrast with around 18% of women who will be screened based on symptomatic or history of risk of infection. Next slide. If we look at the clinical manifestations in pregnancy and postpartum, what we see is that there's no difference between how COVID-19 is manifesting in pregnancy or postpartum period in women, with most of the women presenting with fever or cough, around 40% of them. Regarding laboratory, lymphopenia and rise C-reactive protein are the main findings, and around 2/3 of them will present some radiological findings. Next one. However, when we compare women with pregnant women and non-pregnant women in reproductive age with COVID, what we see is that it seems to appear that pregnant women present with less symptoms than the non-pregnant woman. And this is mainly for example, fever or myalgia, less clear for cough or difficulty with breathing. However, this we thought is an important finding, as clinicians may be aware that maybe pregnant women are presenting with less symptoms. We don't know also if this is related to how pregnant women have been tested, as for example, a lot of these studies are using universal screening. So of course, a lot of these women won't present with severe disease or will be asymptomatic or pre-asymptomatic at the time of the testing. Next slide. So I have 3 other slides presenting you some outcomes. So this first one still compares pregnant and non-pregnant women with COVID. And what the studies are showing us, although the number of studies is small, only 4 studies with large sample size. So you can imagine that there's a few studies that are driving these results, is that pregnant women with COVID seem to have a higher odds of admission to ICU unit, 1.6, and also of need invasive ventilation, close to 2. However, there's no difference in terms of mortality. Next one. And then when we compare pregnant women with and without COVID to look at pregnancy outcomes, we also see that those with COVID will have a higher odd of admission to ICU, and also to have a preterm birth, less than 37 weeks. The differences in mortality are not significant, but again, just to warn you that this is evidence that is based on the very few studies that are reporting this type of comparative data. Next one. If we look at perinatal outcomes, only 1 study provides this kind of information, and suggests that babies born to mothers who had COVID had increased odds of being admitted to neonatal unit. However, there's no differences in terms of stillbirth, neonatal death, or having abnormal Apgar score or fetal distress. Next slide. So to summarize and provide you with the key messages of my presentation, as you saw, the prevalence of COVID-19 disease varied according to testing strategy. A pregnant woman seems to present with less symptoms than non-pregnant women in reproductive age. However, this has to be interpreted with caution, as I said before. A pregnant woman with COVID-19 might be at increased risk of requiring intensive care than non-pregnant woman, but it doesn't seem to have higher risk of mortality. However, this is all evidence coming from high-income countries so far. Pregnant women with COVID are more likely to deliver preterm babies and their babies to be admitted to neonatal units. However, there's also a lot of differences in the sense of how these outcomes have been reported. And just wanted to end my presentation saying that as the evidence is increasing and at how rapidly it is increasing, this finding might change very quickly and very soon. And that's one of the reasons why we set up this living systematic review. Next one. And this is just to finish my presentation, and you will have access to these links on the presentation that you can download to the Living Systematic Review, also to WHO guidance around COVID-19, and to the WHO Academy app, where you can find more resources and information on COVID-19 from us. Just the last slide to thank the systematic review team that have been working very hard to summarize this evidence, and to thank you for your attention.
Thank you, Mercedes. That was a really interesting presentation. I think the Living Systematic Review is going to be incredibly helpful, and I enjoyed looking through it after receiving your presentation earlier. I also think there's going to be many questions. It's very interesting that pregnant women and non-pregnant women have different symptoms and severity of symptoms. I'd like to move on and introduce our next panelist. Jurker Liljestrand has been working on reproductive and maternal health in low and middle income countries for many years. His last postings have been in Cambodia for 6 years and thereafter with the Gates Foundation for 3 years. Jurker?
Thank you so much. Hello, everybody. I'd like to speak on why is this an opportune movement to step up the actions to improve care of PPH. Next slide. Do you hear me? Can I have the next slide? Hello?
Sorry, Jurker, 1 minute. Something just happened to our computer.
Okay. So let me start by speaking to the first slide while you're finding it. The first phenomenon that makes this an opportune time is the very rapid increase of facility births that we have seen in the last 20 years. In the 60s, 70s, 80s, very little happened in the world, in low and middle income countries, when it comes to increase of facility births. But since the 90s, we have a very rapid increase of facility births. This means that countries as diverse as Malawi, Democratic Republic of Congo, Cambodia, they are countries that all have over 90% of births, all births in facilities. Of course, if we speak to this slide, Debbie already pointed out, Debbie Armbruster, that PPH is the biggest maternal killer and is often compounded by anemia. We, for instance, saw a very small study in Uttar Pradesh in India, where we found that 70% plus of all maternal deaths in that geographical area were caused either by PPH or anemia, or a combination of those. We could also say or argue that PPH is most amenable to action. That's by a number of sub-studies that I will show where you can find on my last slide. They show that by concerted effort in a small geographical area, in a province, in a part of a country, you can really have enormously surprising results when it comes to saving mothers from PPH. And that means that if we can improve PPH control in countries, this alone would help us reach the SDG for maternal mortality by 2030. There are 3 new perspectives that have made FIGO act. Next slide. This is the large increase of facility births. This is a slide from the Lancet series on maternal health from September 2016, and you see the very rapid increase. There's really a change in the ecosystem of human birth that society has provided us. When women start bleeding too much during a home birth, there's very little we can do actually in most cases. But if you are in a facility, that provides the potential for doing something. Next slide. So we then have a number of either new or refined methods for PPH control, treatment of PPH, or the prevention. And we could mention things like the intrauterine balloon tamponade, where we have now, in the last couple of years, an emergence of 2 types that are really priced for low-income countries or where the resources are limited. We're not speaking $200–300 for a disposable device. We are speaking of the Elavi UBT that is produced in South Africa by Sinapi, price point around $12, also being sold by UNICEF. And then we have the every second matters UBT that has been fine-tuned by a team at Mass General Hospital in Boston. And that has just been, a couple of months ago, been certified by the Food and Drug Administration in the US, which is important. The non-pneumatic anti-shock garment has emerged on the market and been extensively tested and researched by Suellen Miller and her team and others in the world. So there's a number of good publications on the non-pneumatic anti-shock garments that is very effective, especially when it comes to combating the shock following PPH. Tranexamic acid, invented in the 1950s, has now undergone studies that have led to evidence that shows that injecting tranexamic acid in women who are bleeding too much after birth is an effective intervention, and that is now being recommended by WHO guidelines. Heat-stable carbetocin is currently not recommended for PPH treatment, but for prevention. And of course, it's also one of these new refined methods. Then it comes to the question of how can these be applied? How can they be given and provided? And here a new approach to actually bundling them was discussed extensively at a WHO expert meeting 2.5 years ago. Will you click on the slide, please? And this led to a conclusion that there are two potential bundles here, that you bundle 4 things. When you have a woman who's bleeding very heavily in front of you or bleeding more than she should, you do 4 things without thinking. You give uterine massage, IV fluid, crystalloids, uterotonic, whatever you have, or combine 2 if you have that, and tranexamic acid. This should be the standard approach that is now being researched and tried out. That don't try to distinguish and do some of these things, scratch your head, do one more thing, do another thing. No, just do these 4 as a blanket treatment. And this blanket treatment helps us to standardize PPH treatment and to simplify. Think the simplification of oral rehydration. How can we reach that level of simplification when it comes to PPH treatment? Most people, most women who bleed after birth, they will be taken care of and cured by this first bundle. However, if you happen to belong to the around 5, 4, 5, 10 women with refractory bleeding per 1,000, 4, 5, 10 per 1,000, that's more or less the same number we see everywhere. Women who do not respond sufficiently to this first bundle, then you come in with aorta compression or by manual compression if you're good at that. Apply UBT and consider the non-pneumatic anti-shock garment. So that's your second bundle for a very small group of women. If you combine these things, you will have very good results. Next slide. All of these can be done at the primary healthcare level. Actually, when we think of referrals, actually putting a woman in a transport, in a vehicle to get to a hospital to get any of these methods is often a death sentence, as we all know. If she's bleeding heavily and in shock, not doing these things at the primary healthcare level may lead to her passing away on the way. If you want to do this at the primary healthcare level, which is actually necessary, these women are coming, we have large proportions of your birthing clientele giving birth at the primary healthcare level, you have to support these primary healthcare units. Please click. Click. Can you click on the slide? This requires a support in the network. You cannot achieve these things if you see an isolated health center with a few midwives or other staff working there. It requires support in the networks. And this is something that the WHO is now working on in their new strategy revision for maternal health, networks of care. Click. So here's one example of networks of care. A few committed individuals at the referral hospitals should have as a responsibility to look after the primary healthcare facilities, the health center staff, midwives or otherwise, that work in their catchment area. This needs to be convened by the PHC, the primary healthcare office. Click, and you will then be able to give feedback to them, support them, give clinical updates, intensify training, sit down and do troubleshooting Debbie spoke about data that you actually need to see, are these methods available? Are they being given? And if not, why not? So networks of care is a key component of health system strengthening to be able to deliver these interventions that I just spoke about. Next slide. So a little bit more ambitious. You can see the clinical interventions are here in the sand-colored balloon at the top of the slide, but you need to work with facility readiness and supply chains. You need to work with the network of care, the data, monitoring, teamwork and communication, but networks of care not leaving those primary healthcare facilities all on their own out there, but somebody must look after them. This network of care is now something that's being conceptualized and that we are working on showing how that can work. Next slide. Finally, this is a new website powered by FIGO, savemothers.org, where it's all devoted to PPH, and you can find country case studies, reports. We need more of those on the slide. You will find things like a new systematic review summarized, systematic review on UBT that's coming up in this conference, of the two major strategies that are trying to deliver and provide the tools and methods for really coming out with a comprehensive set of two bundles to improve the care of PPH women. Thank you so much.
Thank you, Jurker, for setting the stage for why now. I think it's clear, as you state, from the large increase in health facility births and these newer refined methods that you listed, like TXA, heat-stable carbetocin, anti-shock garment, and others, that all can be done at the primary care level, speaks volumes, especially when combined into networks of care for health system strengthening. So with that, I would like to introduce our next speaker. Mariana Widmer is a technical officer at the Sexual Reproductive Health Department in World Health Organization. She's a biochemist by training with a master's in science and bioethics with almost 18 years of experience in the area of maternal health research. Mariana?
Thanks, Cherry. Thanks for introducing me. And good day to everyone. Today, I'm going to present some epidemiology related to PPH. I will go through the PPH rates, causes, and severe maternal outcomes. And I will finish my presentation by mentioning the progress that we are doing in the area of PPH in the last years. Next, please. So let's start with the definition of PPH that everybody knows, but just to refresh, PPH is defined as blood loss of 500 mL or more within 24 hours of delivery. It is indeed the leading cause of maternal death worldwide, and based on the last available estimates, we know that 27% of the maternal deaths are due to severe bleeding. What is important to know is that the majority of these PPH-associated severe morbidities and deaths could be avoided by the use of prophylactic uterotonics during the third stage of labor and appropriate treatment. Next, please. So which is the rate of PPH? Based on a systematic review published in 2008, the overall rate of PPH is around 6%. However, this rate varies according to the mode of delivery, the country that we are looking at, whether it is reported by a research study or by observing clinical practice. For example, in the first column of this table, I'm showing the research. We look at 2 WHO PPH trials conducted in the last 10 years with a big sample size. The rate found was around 9% in one and 13% in the other. And these rates are not the same as the ones that we found then if we look at country level. If we want to compare these with the rates informed by the clinical practice, I suggest we refer to the WHO multi-country study that we conducted several years ago, or the cross-sectional study in Nigeria published last year, where the data collected was reported as by the health providers. So in this case, the rates reported were of 1.2 and 2.2%. As you see, these rates are much smaller than what is found in clinical trials. So what we think that happens is that in normal practice, only the severe cases of PPH are recorded in the hospital records. And this is why the rate is lower than what research reports. So let's look now at the second column of this table. This is severe PPH blood loss of 1,000 mils or more, and the overall rate reported by this systematic review is around 1.8%. Again, this rate varies with the mode of delivery, the sample sizes of the trials, and the type of blood loss assessment. This overall rate is similar to what has been found in the research in these 2 WHO PPH trials, and again, varies from country to country. Now, in the third column of this table, I'm showing the refractory group. This is a group of women who bleed and that they don't respond to the first-line treatment. And then they will have to receive additional uterotonics, a second dose of tranexamic acid, maybe a uterine balloon tamponade or invasive surgery like hysterectomy. So we say that these women have a refractory PPH and they represent approximately 16% of women with PPH. This is based on an analysis that we did on the CHAMPION trial. So why I'm mentioning this group? Because this group is very important because they are the ones concentrating most of the severe morbidity rate due to PPH. Next, please. So let's look now quickly at the causes of PPH. This graph shows the sole causes of PPH found in the CHAMPION trial in women who bled 1,000 mils or more and received uterotonics as treatment. So the orange bars represent women with refractory PPH, and the blue bars represent women with responsive PPH. If we look at the group of women who had a PPH and responded well to the first-line treatment, we see that in more than half of these women, atony was the sole cause of PPH. Then we have tears and we have retention of placenta. If we now look at those women who had PPH but did not respond to the first-line treatment, the percentage of women with PPH due to vaginal or cervical tears is similar than those with atony. So why I'm showing this? Because it is very important to identify the cause of bleeding. So you see, if women with refractory PPH, we have almost 50% of probabilities that it's going to be because of atony, but also because of trauma. And if it's trauma, then women may benefit from being transferred without delay to a setting in which upper vaginal or cervical trauma could be effectively treated early. And this is very, very important. Next, please. So we said that hemorrhage is the main cause of maternal mortality, but it is also the main cause of severe maternal morbidity. So in order to understand the factors associated to maternal survival in life-threatening clinical situations, and therefore be able to improve the quality of care, it has been proposed to look at the severe maternal outcomes, what we call SMOs, rather than looking only at the rate of death. So the SMO includes maternal near miss and maternal deaths. And PPH maternal near miss includes hysterectomy, blood transfusion, admission to ICU, and hypovolemic shock. Next, please. So how often do SMOs occur? In this slide, I'm showing the SMOs reported in a secondary analysis of the Nigerian near miss and maternal death survey, which included 42 public tertiary hospitals and collected data from 2012 to 2013. So the study reported 17% of severe maternal outcomes. And from these, 71% were near miss cases and 29% were maternal deaths. So if we look at the characteristics of these women with severe maternal outcomes, we see that mostly were women between 20 and 35 years old, had more than one pregnancy, belonged to a low social class, lived in a place more than 5 kilometers from the hospital, and were unbooked. So the study found that those who had a cardiovascular or coagulation dysfunction had a better survival than those who had a neurological, renal, or respiratory dysfunction resulting from PPH. Next, please. And what is very interesting and at the same time sad is that almost 84% of women with SMOs were brought to the hospitals in Nigeria already in critical conditions. So this highlights the importance of early detection of PPH and rapid referral. Next, please. Availability, accessibility, and appropriateness of emergency obstetric care are factors that determine survival from hemorrhage when it occurs. As I said at the beginning of my presentation, many of these severe morbidity cases or deaths are preventable. And this is proven by a very nice review done by Sue Focus on the obstetric deaths in South Africa between 2014 and 16. So in this review, 87.8% of the obstetric deaths were judged to be possible avoidable. Almost 88% of the deaths were avoidable. And while 33% were due to a delay in seeking care, 66% were due to what we call the administrative factors, just like lack of trained doctors, delays in transport between institutions, lack of blood, or delays due to overburdened services. What is interesting is that the Nigeria study that I mentioned before, they have similar findings. So availability of trained personnel who could trigger the PPH bundle of care at the earliest sign, timely intervention with life-saving treatments, as well as treatment initiation before referral, were the factors associated with severe maternal outcomes. So we can say that early diagnosis of PPH, early detection of the cause of PPH, and appropriate treatment by a trained health provider with good quality medicines are very important factors to consider if we aim at improving outcomes. Next, please. So considering what I have presented up to now, let's look very quickly at the progress done in this respect. Regarding PPH prevention, we all know that PPH can be prevented with the use of an effective uterotonic during the third stage of labor, and that oxytocin is the drug of choice. However, in many places, mainly due to problems with the cold chain, the quality of oxytocin is not as expected. And therefore, for years, we've been claiming the need for a heat-stable uterotonic. So the good news is that heat-stable uterotonics, now we have them, we have identified them. This is the heat-stable carbetocin that is as effective as oxytocin, is now available and is now included in the WHO Essentials Medicines list. In addition, we updated the WHO recommendations on uterotonics accordingly. Regarding PPH treatment, as I highlighted along the presentation, delayed use of effective interventions for the treatment of PPH, in addition to other systemic problems in health services, has led to continued unacceptable rates of PPH. So if we want to improve the current situation and ensure high adherence to PPH guidelines, we need to have trained health personnel available to treat these women. One way to do this is by following the bundle approach that it has been just mentioned in the previous presentation. So in December last year, WHO published the definition of the first response bundle for the treatment of PPH due to uterotomy. And this bundle consists of administration of uterotonics, fluids, tranexamic acid, and uterine massage. We are now at the point of starting the eMotive project, which is a multi-country trial that will evaluate the implementation of this first response bundle. Let's look now at the refractory PPH. So WHO just updated their recommendations on the use of UVT for refractory PPH and will soon embark in a trial to evaluate the effectiveness of different uterotonic devices that have been developed in the last 2 years. And last but not least, we know that we can invest in identifying new medicines. We can invest in training health providers in how to use these medicines. But if the quality of the medicines is low, we will never be able to reduce PPH. Therefore, we are working hard trying to improve the quality of the uterotonics used at the bedside. And we have several projects ongoing looking at the quality of oxytocin and other medicines. Next, please. So in summary, early diagnosis, adequate surveillance for prompt identification of any sign of deterioration, and timely intervention are essential to determine survival from PPH. Therefore, an improvement in the quality of maternal health care is critical to prevent and treat the maternal life-threatening conditions. There is still a long way to go, and in order to ensure success in reaching the SDGs health targets, we have to join forces and work together. So I'm very happy to participate in this conference, and I hope that it's very productive and we can learn lots of lessons. Thank you very much for your attention.
Thank you, Mariana, for your presentation and sharing the progress that we've made in PPH and the progress that is still yet to be achieved. I think the number that always stuns me, and this isn't new to any of us, but nearly 90% of obstetric deaths in that South African study from hemorrhage were avoidable, and that 66% were from the third delay. So once women were there, the system did not fully work. I would like to introduce our last panelist. This is Dr. Louis Gadama, obstetrician gynecologist and senior lecturer at University of Malawi College of Medicine. His research interests are in maternal morbidity and mortality, and he's currently evaluating the integration of maternal near misses into the pre-existing MDSR system in Malawi.
Right. Good afternoon, good morning, good evening to you all. Next slide, please. So the outline of my presentation really will look at how we are doing with the maternal death surveillance and response system in trying to answer the questions on around postpartum hemorrhage. So I'll take you through in terms of how this came about and any strategies that have been outlined and how are the countries faring through. Next slide, please. So this is a process, and it's one of the global strategies that were started in 2013 by WHO, and the main role really was to end preventable maternal deaths, and it's a response cycle. It starts with a case review of maternal deaths, and then after that, then they need to be commitment to real-time actionable data, which helps to present future similar deaths. Aggregation and interpretation responses should be coordinated or with a commitment from the national level within the governments, and there should be a proper monitoring and evaluation system within the MDSR and an implementation plan. So as you can see with this process, several countries have come up with reports. I know with South Africa, they've got the Saving Mothers report that they always give annually. Within the country, within Malawi, we always have our reports that are also generated either biannual or triannual with regards to the MDSR process. Next slide, please. So there are always hiccups that have been noted in terms of fully implementing a sound MDSR system. One is the lack of awareness of the purpose and the principles by the stakeholders on the role of the MDSR. At national level, there's no political commitment in some countries, lack of financial resources that are put in place to support the MDSR committees. Also, when these cases are being reviewed, there's always existence of a blame culture during reviews, such that the health workers on the ground, they feel not obliged to participate, as they always feel that there's always a blame game that will be given to them for causing the maternal deaths. There's also a mindset to reflect and effect change, which is not present in most of the committees. So the main issue is about coming up with actionable recommendations that then drive in to prevent future maternal deaths. There's also insufficient number of trained health workers that are there within the facilities. Thank you. Next slide, please. So why are we discussing maternal deaths? I think really from globally, the statistics from 2017 has reported that we've got 205,000 maternal deaths that were reported. Sub-Saharan Africa alone contributed 66% of these cases. And within Sub-Saharan Africa, the lifetime risk of a maternal death is 1 in 37. This is for an adolescent group. And this, if you compare with the high-income countries, really, it will be 1 in 4,000 something. So according to the Director General of WHO, really mentioned that in countries that provide everyone with safe, affordable, and high-level health services, women and mothers survive and thrive. So we're using this statement really to see how much we can do, any strategies that can be put in place to help women and babies survive and thrive. Next slide, please. So there's always a synergy that has been noted between the MDSR and the emergency obstetric care assessments. All these two systems, they always try as much as possible to speak to the three delays, which is by previous speakers already mentioned in terms of where most of our deliveries are happening in the health facilities, but you'd find that most of the countries have got high deaths. And also the factors that are affecting service utilization, really they cut across all the three delays. We've got the socioeconomic and cultural characteristics that would affect the first delay, accessibility of health facilities that would also lead to the first and the second delay, and the quality of the services that are being provided within the facility. Next slide, please. So this slide really emphasizes that postpartum hemorrhage still tops the big five causes, direct causes of maternal deaths. And this is why we are all in this forum to try as much as possible to see how best we can avert or prevent this 27% being reduced to a significant lower number. Next slide, please. So what we've learned so far is that postpartum hemorrhage is the leading cause of maternal deaths. Problem recognition is still an issue, though we've got most of the deliveries or most of the care being provided for by skilled health birth attendants. Availability of blood products is still a challenge in most of the facilities. The data capturing process of these cases is not efficient. The uptake of medical surgical interventions to control PPH still shows a gap. There's the bundle approach that has been proposed. In most of the lower middle income countries, cesarean section rates is on the lower side. Supplies of medical interventions are erratic, and life-saving interventions for postpartum hemorrhage not readily utilized in the hard to reach areas. Next slide, please. So what more could we learn? Really, the main issue is about investing in the data capturing process, the health management system, having a real-time data system. We saw the flow feedback mechanism being provided timely. Also integrating health processes that capture both morbidity and mortality. There's the concept of the near miss being combined with the maternal deaths. So within the maternal death surveillance response team, having that approach to capture the near misses. So the inclusion of maternal near misses in the death review is necessary for a number of reasons. Why? We have got more maternal near misses that occur in the facility than maternal deaths. Surviving a near miss is mainly because of the care that has been provided, and such reviews really will give a potential highlighting deficiencies and positive elements that can be shared within the health system. Because the mother survives, she can provide valuable details, or the mom can also tell a story on how she has been cared for. Blood products usage can be tailored to clinical outcomes and create clinical dashboards that can reflect quality of care and workloads. Next slide, please. Right, thank you. So this is what I really prepared for you. Thank you very much.
Thank you, Louis, for reviewing MDSR in Malawi and sharing what you've learned, and also the value of adding near miss to the MDSR. It is time to turn to question and answers. I would like to thank the panelists for your really great presentations. We have a lot of new information, and there are a number of questions. So a couple of logistics regarding questions. Please do add your questions to the question and answer section, not the chat section, so we can capture them. And also for the panelists, you have the ability to go in and actually write answers to questions. So we may not get to all of them in the oral part of the Q&A right now, but we will get to these questions. So let me capture the first few questions. Okay, from Megan Mary. Given the issues in stock management and conservation in low and middle income countries, especially at the primary healthcare level, how can we promote blanket treatment bundles? What evidence do we have that the 4 proposed interventions work better together compared to, say, 3 or another combination of interventions? And I think this is speaking to cost efficiency.
Can I comment on that, Cherry?
Yes, please.
Thank you very much for that very interesting question, Mary. If we look at what is in the first bundle, the one that is now being tested for effect by Emotive, the study that was mentioned, uterotonics, would anyone here deny a woman who's bleeding without a clear diagnosis, she's bleeding postpartum, would you deny her an extra dose of uterotonics, or perhaps 2 if you happen to have it? You're uncertain if your oxytocin is effective or not. You may want to apply some other method to some other uterotonic. Tranexamic acid, we have new recommendations from WHO. They are not being implemented to the scale that we hope and want, and WHO and many other partners really want us to say, okay, if she bleeds too much, she should have tranexamic acid. So then we really boil down to the drip. And there I give you right. Can we afford to put up a drip with a crystalloid substance? It's cheap and the woman needs it, but can we afford it, or do we need to save them? For the refractory bundles, we are speaking about, again, a woman who is a small minority of women, about less than 10 per 1,000 birthing women, perhaps 5, perhaps 4, and they are deteriorating and bleeding to death. At the primary healthcare facility, many staff, majority of staff in the countries I have worked in, they will not be able to make a diagnosis of a cervical tear. So should they put on an anti-shock garment or a balloon tamponade or both? Are you going to withhold that treatment for economy reasons? I think we will see some other responses in the Emotive trial. Over, thank you.
Okay, Yerker, thank you for that. The next one we have is from Jeff Smith for Dr. Widmer. A prior WHO analysis identified 3 major factors related to postpartum hemorrhage mortality: cesarean section, maternal anemia, and poor quality care. Do those factors still impact PPH mortality?
Yes, they are still impacting, unfortunately, mortality. And actually, we are looking into the cesarean section and quality of care in our Emotive project, in the bundle project. So we are still looking at these things, yes.
Okay, well, I think we have time for one more. The next one is from Kathleen Hill. This question is for Dr. Yerker and Dr. Mariana. There appears to be a tension between a PPH platform that promotes a universal primary care PPH bundle at the PHC level, which makes very good sense, and a broader platform that acknowledges importance of early determination of the cause of PPH and treatment based on cause, given that trauma, vaginal, and cervical lacerations are responsible for approximately 30% of severe refractory PPH per Dr. Widmer's presentation.
I can start again. So I spent 6 years in Cambodia, and Cambodia is a country that reached MDG 4, 5, and 6, and there are very few countries that did that. In Cambodia, 90% of the births are at health facilities, but of those, 2/3 are at primary healthcare facilities. And again, we have some skilled midwives, but you also have semi-skilled staff, and actually spending or wasting or spending time on trying to figure out the exact diagnosis may be less of a feasible option if you really want to apply obstetrics from a public health perspective. So I would think we have a lot of learnings when it comes to bundled approaches from behavior studies. When you study behavior, the whole idea of a bundle of having 4 or 5 things, not more, is that you will remember them better than if you scratch your head and say, well, what was it I was going to do here now? Well, first I give this drug, let's see how she reacts. We have very little time. We know that PPH evolves often very, very fast. So a public health minded approach, that's where the bundle approach comes. And you have then studies from countries that have done this. Maharashtra in India are doing this. They are now down to a maternal mortality under 40. We have Northern Nigeria, the prize-winning project by the Clinton Health Access Initiative and local partners in Northern Nigeria. And even in one of the poorest countries in the world, Niger, they are doing this kind of standard approach. Yes, diagnosis is good for those who reach the hospital, but at the primary healthcare level, to really mobilize people and inspire people to save more mothers, do these 4 things. And if you still have problems, think of the next couple of things. Over.
Yeah, and I would like to add that also referral is very, very important. I mean, when you cannot make the diagnosis, the correct diagnosis, you need to be able to make quick, fast referral and give some attention to the woman during the referral. So I agree with the need of bundles, but I also need, we need the referral, pay attention to the referral of the woman. Yes.
All right, thank you. And there's a number of other questions that are popping up in the Q&A. We will keep our eye on those. We will be answering them, and the panelists, I welcome you to go in and answer any that are directed specifically to you. And at this time, I'd like to turn this back over to John Varello. John?